Hello and welcome to this short series of lectures about the stomach. We're going to start things off by looking at some normal gastric appearances, and then over the next several lectures look at abnormalities and look at a few different common diseases that are seen, especially focusing on the small animal stomach. You'll see various abbreviations through the course of these lectures. Here are the ones that you can come back to for reference. The objectives are not too surprising. Identify procedures that we can use to evaluate the stomach, what their advantages are, what their disadvantages are, recognize the normal appearance of the stomach on survey radiographs as well as with contrast procedures, and then know about the pathophysiology and findings in various disease states of the stomach. So here's the list of things over the next 4 segments of lecture that we're going to do. Start with the general workup for the stomach. Imaging is useful and is indicated for a variety of reasons. Most of the time, you're looking at the stomach when you're suspicious of gastric or gastrointestinal disease. So when the patient's vomiting, or there's cranial abdominal pain, or there's melena, various signs that specifically point, or at least can point to the stomach. And you can also use radiographs or other imaging to evaluate any complications that may be associated with diseases of the stomach, such as peritoneal disease secondary to gastric rupture. We have a number of means of imaging the stomach. Survey radiography is always a first step, or most of the time a first step. Contrast radiography, contrast fluoroscopy are going to be really important as well. Many different modalities can give you structural information. If you really want to know about the function of the stomach, you really are looking at fluoroscopic evaluation or contrast radiography to look at passage of contrast medium through the GI tract. Survey radiographs are pretty useful for some things. If you want to look and see if there's a radiopaque foreign object, you know the patient ate a battery and you want to see where it is, that's going to be pretty helpful. It's also very useful for diseases like gastric dilatation and volvulus, or gastric dilatation without volvulus, because you can make a fairly solid diagnosis of those pathologies. There are some notable limitations with survey radiographs. Non-radiopaque foreign objects are often not visible unless there's just the right amount of gas in the stomach to kind of highlight them. Many wall lesions are not going to be visible on radiographs. Ulcers, certainly not. Small masses you probably won't see. And then with survey radiographs, we really can't assess gastric function or motility unless you take serial radiographs and kind of follow gastric distension and gastric contents over time, in which case at least you can get a little bit of an idea of function. Repeat radiographs are useful, so don't forget about that as a possibility. If the stomach is relatively full on the first go and you want to see if things pass, radiograph it later, 4 hours, 6 hours, 8 hours. Contrast procedures are usually still better for assessing motility, but in many cases repeat radiographs are still helpful. Upper GI series, or we're going to focus on the stomach, so positive contrast gastrogram, are pretty commonly used in practice. We use them mostly for a couple of reasons. The main one is we take survey radiographs and there's something that catches our eye and we're not clear as to how concerned we should be about this lesion. Upper GI series can also be used to identify a foreign object that may not be visible on survey radiographs, as well as to identify mural or mucosal lesions like masses extending from the wall. Don't forget, again, I'm going to focus on the imaging here for obvious reasons, but there are other ways to assess the stomach. Endoscopy is great for evaluating the mucosa, look for ulcers, potentially find foreign bodies, and then exploratory surgery is also a valid approach, at least in some circumstances. So what does the stomach look like normally? Normally the wall is a soft tissue opacity. The lumen is variable. It usually has various combinations of gas and fluid, as well as other heterogeneous ingesta, which may be more soft tissue opacity, can have some mineral components to it depending on what the patient's diet is. Sometimes we'll see the rugal folds. It depends how distended the stomach is. If it's kind of moderately distended and has gas in it, we can often see them. If it's too collapsed or too fluid filled or too distended, usually we don't identify the rugal folds. Remember the shape of the stomach. There's a large fundus and a not as large pyloric region. There are 2 curvatures, a lesser curvature more cranially and a greater curvature more caudal. Shape changes a little bit on a VD or DV view, but not enough to probably matter. On a dog, the position of the stomach is relatively horizontal on a VD or a DV view, whereas a cat has more of a J shape to it, with the pylorus sitting nearly superimposed on the spine. There are normal shape changes to the stomach because there's normal peristalsis, so transient narrowings are usually not of any consequence, but a persistent narrowing might be something you have to be concerned about, as it could be a stricture. Usually don't see those as much in the stomach as in the small intestine, but other thickenings or misshapen areas, if they persist, can raise concern for a mass. So here's what the stomach is supposed to look like on a dog. Got variable amounts of gas in the stomach, so not too distended. Here you can see it's relatively horizontally positioned in these two dogs. In this one you can even see the duodenum coming out of it, so just the right amount of gas. So this is a typical appearance for the stomach on a VD or a DV view in the dog. Contrast that to the cat, where the position's not quite so horizontal. The shape is a little bit more, it's a little more obliquely oriented to J-shaped. Again, the pylorus is often a little closer to midline than it is in the dog. Size is really variable. An empty stomach is obviously not that big. A distended stomach gets a lot bigger. There's not really a cutoff as to how distended is too much for a stomach. So you have to kind of use clinical signs and radiographic findings to decide how much distension you think is appropriate or not for a patient. The larger question is does this dilation disappear over time, or does it persist? So persistent dilatation is going to be much more concerning. Is there some reason that food and other ingesta is not leaving the stomach, i.e. is there an obstruction or is there a functional ileus? Thus, you will often need either a contrast procedure or serial radiographs with fasting the patient to see if the contents of the stomach are leaving appropriately. If you keep feeding the patient, you're not going to be able to identify how fast the stomach is emptying. Wall thickness is not something we can really evaluate on survey radiographs because any fluid in the lumen is going to silhouette with the wall, so you don't really know how much of the tissue is wall and how much is internal contents, and the same goes for small intestine and the rest of the GI tract as well. So if you're really curious about the wall, you're going to need to do something like a gastrogram or ultrasound or CT. Location is important. We saw the normal position of the stomach overall in the dog and the cat. The fundus is dorsal and it's in the left cranial abdomen. Pylorus is ventral and on the right. Again, a little more close to midline in cats. And that's really important to remember those associations because we're going to come back to that when we talk about gastric dilatation and volvulus. When we look at the gastric axis, which is the line from the fundus to the pylorus, that's important not so much for the stomach as maybe for the surrounding organs, because if there's enlargement of the liver or a small liver, that's going to shift the way the stomach lies. And so identifying the gastric axis can be helpful for assessment of other organs in the abdomen. On the lateral view, that axis should be about parallel to the ribs or perpendicular to the spine. A little bit of variation depending on if it's a deep-chested dog or not. And then on a VD view, it really should be perpendicular to the spine. Here's a normal dog. I can see the fundus and the pylorus. Again, I'll back up a slide here. Gas in the fundus here, gas in the pylorus here. So you can draw a line between the two, and that's your gastric axis. It's basically parallel to the ribs, so that's really what it should be. On a VD view, similar story. Fundus on the left, pylorus on the right, mostly perpendicular to the spine, which again is about right. There's also usually a little bit of variation as to exactly where it sits, but generally the stomach sits somewhere over the 10th to 12th thoracic vertebra. So like I alluded to just a couple slides ago, when you see a change in the position of the gastric axis, you usually think about other organs, and the liver is really number one on that list. So if the stomach is shifted caudally, either generally big liver or a hepatic mass causing that. If the stomach is shifted cranially, the liver is often too small. Maybe there's a diaphragmatic hernia. Certainly there are other masses of other organs that can cause shifts, but again, the liver is the biggest player. And usually masses or other lesions of the stomach itself don't shift the axis that much. As you look at the appearance of the stomach on the various lateral VD and DV views, you have to keep patient positioning in mind relative to gravity and just basics of gas goes up and fluid goes down. And so as long as you remember where the different structures live, i.e. fundus is on the left and dorsal, pylorus is on the right and ventral, and And remember that the pylorus is smaller than the fundus. You can use that to sort out the different recumbencies and what the stomach should look like with the patient in different positions. Again, this becomes important as we go down to looking at gastric dilatation and volvulus, where the various parts of the stomach are not located in the appropriate places. So depending on the view, again, knowing who lives where, you can sort out what the stomach should look like. So for example, on a right lateral view, I know the pylorus is on the right side of the patient, so that's going to be the downside of the patient, so it should have fluid in it. And fundus should have gas in it because that's on the gravity, the non-dependent part of the dog. And then you can go through the various other positions and orientations to figure out who will have gas in it and who will have fluid in it. So if we look at this in a schematic sort of sense, here's the stomach. I've got the directions labeled. Fundus is large and on the left and dorsal. Pylorus is smaller and on the right and more ventral. And so if we have a dog in dorsoventral view, so he's in sternal recumbency, he's lying on his sternum, so up is up and down is down relative to gravity. Our x-ray beam coming from top to bottom, as you can see with the arrow. If there is going to be fluid, it's going to collect like this. So again, ventral is down toward gravity, so there's going to be gas in the fundus, and so it will be visible. The fundus will be visible as a gas-filled portion on the left side of the animal. If we turn the dog over, which is more common, do a ventrodorsal view of the abdomen, you can see that fluid will collect now in the more dorsal part. So again, still gravity dependent, and so on a VD view, you're going to see gas more in the pylorus, which should, again, if it's normally positioned, be on the right side, and you're going to see fluid in the fundus. Now, the caveat here is exactly what you see depends on exactly how much gas and how much fluid are in the stomach. So if there's less gas and more fluid, both the fundus and pylorus might look fluid-filled, and if there's a lot of gas and not much fluid, it all might look kind of gassy. So again, you have to kind of take all of these broad generalizations with a grain of salt. So here we have a dog. He's on his back, so it's a VD view. I can see that there's fluid in the fundus on the left, gas in the pylorus, and pyloric antrum on the right. Scoot back so you can see nice fluid-filled fundus, gas-filled pylorus. That's exactly what it should look like for a VD view. In right lateral recumbency, so the dog is on his right side. Again, fluid is still going to collect on the gravity-dependent portion, so now that's the right side of the dog. So the fluid will fill the pylorus, and the fundus will be gas-filled, and you'll see that on the dorsal aspect of the radiograph, just like this. So right lateral recumbency, there's fluid in the pylorus, gas in the fundus. Again, we're seeing more of the body here because there's a little bit more gas in this patient's stomach. And then rolling the dog over, so now left lateral recumbency, any fluid in this stomach is going to collect again on the downside of the patient. Now that's the left side, so it's the fundus in this case, and you'll see gas in the pylorus, and I know the pylorus lives ventrally, so hard to see the fundus because it's fluid filled. I can easily see the gas in the pylorus and the duodenum because those are on the right side of the dog, and that is thus the upside since this is a dog in left lateral recumbency. And that's all you need to know for the basic normal appearance of the stomach. In the subsequent chapters here, we're going to talk about various abnormalities of the stomach.